Hello dear respected students, today we are continuing discussing hematological disorders, and I'd like to give today hemorrhagic syndrome or hemorrhagic diathesis. Hemorrhagic syndrome is a condition which is characterized by excessive bleeding due to defect in one or more components of the hemostatic system. Before discussing hemostatic disorders, I'd like to remind you normal hemostasis. Normal hemostasis involves the physiologic balance of procoagulation and anticoagulation factors that maintains liquid blood flow and the structural integrity of the vasculature. Of course, main tasks of the hemostatic system are providing laminar blood flow and also, if needful, local hemostasis. There are main players of normal hemostasis, procoagulation and anticoagulation factors. Procoagulation factors includes vascular rules, platelets, and 13 coagulation factors. And anticoagulation factors, there are fibrinolytic system, antithrombin 3, APC, activated protein C, and protein C and S, and also tissue factor pathway inhibitors. Normal, non-damaged endothelium has very important role to maintain the laminar blood flow because has antiplatelet effect by inhibition of platelet adhesion, activation, and aggregation. Also, normal endothelium produce the prostacyclin, which is vasodilator and antiplatelet agent. Also produce the nitric oxide, both bind with the receptors on the platelets and inactivate them, so inhibit platelet aggregation. ADPase, enzymes that break down the ADP, strong pro-aggregative agent released by the platelets and thus inhibit platelet aggregation. Injury of vessels cause activation of primary hemostasis, which includes the vasoconstriction and platelet plaque formation, and cause after that secondary hemostasis, and which cause the wound healing and repairing. Also activate the fibrinolytic system. Primary hemostasis, first physiological response to vascular injury, which mediated by platelets in order to arrest bleeding. Mechanism of primary hemostasis is activation of platelets via stimulation such as thrombin, and then adhesion of platelets to subendothelium via interaction between glycoprotein 1b and von Willebrand factor, release of platelets granule products in order to recruit more platelets to the injured site, aggregation of platelets via interaction between glycoprotein 2b and 3rd factor and fibrinogen to form the initial plaque, and also triggers secondary hemostasis or coagulation proteins. Within 1 to 2 seconds after injury to blood vessel, hemostatic process begins and proceeds as outlined below: platelet adhesion and then platelet activation, platelet release reaction, and platelet aggregation. You see here inactive, weakly activated, and activated platelets, which result in process of centralization and platelet degranulation and platelet adhesion aggregation processes. Secondary hemostasis, process of blood coagulation. Coagulation proteins work in concern to generate thrombin. Thrombin converts fibrinogen to fibrin. Fibrin consolidates the platelet plaque made in primary hemostasis such that a thrombus secondary hemostatic plaque is formed, which prevent further blood loss from the injury site. Fibrin deposition and fibrinolysis must be balanced during repair, and injured blood vessel will injured vascular endothelial cells release plasminogen activators like tissue plasminogen activator or urokinase activating fibrinolysis. Plasminogen activator cleave plasminogen into plasmin, which dissolve the clot. And also you should know about inhibition of coagulation cofactors. Inhibitors are protein C, protein S, and tissue factor pathway inhibitor. Protein C is a vitamin K dependent glycoprotein synthesized in liver, and protein circulate as an inert zymogen and is activated by thrombin in the presence of thrombomodulin in the surface of vascular endothelial cell. Protein C, proteolytic destruction of activated 5th and 8th factors. Protein S is also vitamin K dependent protein, acts as cofactor in protein C reaction and enhance the action of protein C. Tissue factor pathway inhibitor limits the action of tissue factor. It's also inhibit excessive tissue factor mediated activation of 9th and 10th factors. And let's discuss hemostatic disorders. There are 5 types: petechial-ecchimatic, bruise, hematoma type of bleeding, mixed ecchymosis and hematoma, vasculitis, and also angiomatose. Let's start from petechial-ecchimatic type of bleeding. This type is characterized by superficial hemorrhages in the skin, not tense, painless, not compressing and not destroying the surrounding tissue, bruising or ecchymosis on the skin which are larger than the petechia in size but also not tense and painless. Petechia and bruises occur spontaneously or with the slightest trauma. Also character gingival, nasal, and uterine bleeding. Main causes of petechial-ecchimatic type of bleeding, of course, thrombocytopenia purpura or thrombocytopenia. Main causes: thrombocytopenia, decreased level of platelets, and thrombocytopathy, normal platelets level, but destroys the platelets functions. Thrombocytopenia may be mostly acquired than hereditary, whereas the thrombocytopenia mostly hereditary than acquired. Clinically may be acute or gradual onset. Petechias and ecchymosis occur spontaneously or after minor injuries, and also character nasal, gastrointestinal or uterine bleeding, or sometimes even hemoptysis. Thrombocytopenia classification: mostly thrombocytopenia occur due to reduction of production of platelets in bone marrow. It may develop due to central mechanism, due to aplastic anemia, leukemias, myodysplasias, even may develop sometimes in B12 deficiency anemia due to decreasing DNA production and decreasing cell division. Also may develop due to chemo or radiation therapy of bone marrow. Sometimes thrombocytopenia may occur due to increasing destruction or consumption. It may develop due to immune or non-immune mechanism. Immune mechanism is developing autoantibodies antibodies to platelets, and platelets destructed by autoantibodies. And non-immune mechanism because overusing or consumption due to thrombosis or may occur in disseminated intravascular coagulation syndrome. Thrombocytopenia also may occur after massive bleeding or in splenomegaly due to sequestration, and sometimes may be hereditary decreased production of platelets in bone marrow. How we diagnose? We diagnose by checking of blood count in blood analysis. In blood will decrease the platelets count and increase in duration of bleeding. For example, Duquet test give us more than 5 minutes bleeding, duration of bleeding, delayed destruction of blood clot more than a day, and in sternal puncture you see decrease in number of megakaryocytes, their functional inferiority, in fastened platelets are not observed, and shortening platelet life. This is determined by means of radioactive chromium or indium. And this test we called as capillary fragility test or Konchalovsky-Rumpel test or cuff test. Assessment is based on the number and size of hemorrhage formed on the upper part of palmar surface of forearm, encircled with a diameter of 5 cm. After 5 minutes of squeezing the shoulder with a cuff at a pressure of 90 to 100 mm Hg. In 5 minutes after removing the cuff, if we have we see petechias more than 10 in a circle of 5 cm, test is positive. And here we have in thrombocytopenia and thrombocytopenia we have positive test because decreasing number of platelets and also decreasing function or destroying function of platelets cause decreasing endotropic function of platelets. Thrombocytopenia is hemorrhagic purpura that occurs when platelets function is impaired. Platelets dysfunction in thrombocytopenia include defects of adhesion to the walls of the vessels. Such a defect is observed in von Willebrand disease. Defects of aggregation. Such a defect is observed in Glucksmann disease. Defective release of mediators that occurs under the influence of drugs, for some drugs, aspirin and etc. Also may present in defects in the deposition of granules in platelets which develop with chronic renal failure. Also may occur due to defect of retraction. Diagnosis: the platelet count is normal or subnormal. Here we have only destroying of functions. Bone marrow examination gives us elevation or normal thrombocytopoiesis. Coagulation time will be within normal because coagulation factors not destroys. The duration of bleeding of course enlarged, and capillary fragility test will be positive, and violation of adhesion and platelet aggregation. And you see here real patient picture, and you see bruises and slightly traumatic regions, and also you see such petechias and bruises. Next type of bleeding is hematoma type of bleeding. This type is characterized by massive, deep, intense and painful hemorrhages in large joints, muscles, under epineuritis and fascia in subcutaneous and retroperitoneal tissues, profuse, sometimes profuse spontaneous post-traumatic or post-operative bleeding, including from internal organs, which often do not occur immediately after surgery or injury, but after a few hours. Main causes of hemophilia A, B, C. Hemophilia, a group of blood disorders in which there is defect in clotting factor. 70% are X-linked recessive disorder, 30% spontaneous mutation. The bleeding patterns of hemophilia are similar. There are 3 types: A, B, C. A is deficiency in factor 8, B deficiency in factor 9, and C deficiency in factor 11. Hemophilia, we have here 3 stages, not 3 stages, 3 types: severe, moderate, and mild. Severe clinically manifestation of severe is manifest in infancy when child reach toddler stage. Spontaneous bleeding in muscles or joints, hemiarthrosis, excessive bleeding after minor traumas, also may correct post-operative or after intramuscular childhood vaccinations. Moderate 1 to 5 of normal percent, manifest after 2 years of life. Moderate trauma causes bleeding episodes, and occasional spontaneous bleeding occurs. And also mild, often diagnosed in teenagers and adults. Significant trauma to induce bleeding, only significant trauma, not mild traumas, and no spontaneous bleeding. How we diagnose Diagnostic test determines the coagulopathies. We see thrombin time normally from 14 to 16 seconds will increase, and increase activated partial thromboplastin time normally from 25 to 39, please my dears, from 25 to 39. And thrombin index normal will be 80 to 100% with prolonged fibrinogen. Normal fibrinogen level from 2 to 4 grams per liter. And also correct hemorrhagic, and you see enlarging of joint, and we have accumulation of blood in joint space. And methods of assessing coagulation hemostasis and mandatory tests, they are Lee-White coagulation time, also enlarged, and activated partial thromboplastin time, prothrombin time, and prothrombin index, and also international normalized ratio, thrombin time, and fibrinogen. There are also additional tests to determine the coagulation hemostasis, determination of blood coagulation factors. For example, in case of hemophilia A, we should check the 8 factor, in B 9 factor, and we can check also other coagulative factors, and also activity and level of von Willebrand factor and inhibitors of factor 8. Evaluation of the fibrinolysis system also is very important. Sometimes in case of disseminated intravascular coagulation, we have to differentiate, we have to check the dimers, fibrin, fibrinogen, degradation products, and etc. Next type is mixed or ecchymosis-hematoma type. This type is characterized by bruising, petechia, and major hemorrhages on the skin, hematomas on the skin, and subcutaneous tissue, nasal, and uterine bleeding. Unlike hematoma, rare joint damage, often bleeding in the mesentery. From petechial-ecchimatic differentiates by extensive bruising. Main causes severe form of von Willebrand disorder, deficiency of vitamin K, and disseminated intravascular coagulation. Clinically manifested may be asymptomatic, but mostly occurs mucous membrane bleeding, epistaxis, and cutaneous bleeding, gingival bleeding, and menorrhagias. Von Willebrand disorder cannot be diagnosed with routine blood testing in complex. Of course, involves measuring a person's level and activity of von Willebrand factor and factor 8. Testing is often repeated because a person von Willebrand disorder and factor 8 levels can vary. Next is vasculitic type. This immune complex inflammation and disorganization of the walls of microvessels with the development of microthrombosis. Examples is of course hemorrhagic vasculitis or Henoch-Schönlein purpura. Henoch-Schönlein purpura characterized by skin hemorrhagic rash on the legs, hips, abdomen, less often on hands and face. Symmetric macular with a hemorrhagic corolla and necrosis in the center. The presence of stage and development of rash elements. Also may appear by joint syndrome, symmetrical ankle arthritis, and or knee joints. Abdominal syndrome is very severe syndrome, may sometimes develop acute abdomen syndrome, and renal syndrome in half of patient may develop renal syndrome as nephritic syndrome and renal damage of central nervous system and lungs. In these disorders formate the immune complexes which circulate in blood and can damage the skin, can damage the joint, abdominal can damage the vessels of GIT system, renal vessels, and rare can damage the other organs. Mostly appear by skin syndrome, and you see here symmetrical generated papules formation. This Schönlein-Henoch diagnosis is typical clinical picture: hyperbilirubinemia, increase immune globulin A and immune globulins M, also circulating immune complexes, increase in cryoglobulins in plasma, increase in plasma from Willebrand factor as an indicator of endothelial dysfunction, laboratory indication of inflammatory activity like sour increase, C-reactive protein or fibrinogen, and capillary fragility test is positive. Next is angiomatous type of bleeding, characterized by stubborn, strictly localized and attached to local vascular pathology hemorrhages. This type is characterized by persistent and repeated bleeding of one or two, less often more localization, for example, nasal or pulmonary, lack of spontaneous and post-traumatic hemorrhages in the skin, subcutaneous tissue. An example is hereditary hemorrhagic telangiectasia or Randy-Weber-Osler disease. Randy-Weber-Osler disease, hereditary hemorrhagic telangiectasia, due to damage to microvessels due to a deficiency of collagen in them. We here don't have destroying of coagulation factors, don't have destroying of platelets, we have destroying hereditary deficiency of collagen in the vessels, and clinics depends on location, which vessels are not have collagen. Autosomal dominant disease, recurrent angiomatous bleeding that occurs more often at 6 to 10 years of age, character nasal bleedings, gastrointestinal bleeding, sometimes hemoptysis, pulmonary bleeding, and uterine bleeding. Telangiectasis on skin and mucous membranes sometimes may appear, vascular abnormalities, angiomas, and arteriovenous shunts in parenchymal organs sometimes observed, absence of significant violation in the platelets, primary hemostasis and secondary hemostasis. And mostly for these patients character prolonged time bleeding and which chronic bleeding which occur the secondary iron deficiency anemia. Next is disseminated intravascular coagulation, is characterized by systemic activation of blood coagulation, which result in generation and deposition of fibrin, leading to microvascular thrombi in various organs and contributing to multiple organ dysfunction syndrome. Consumption of clotting factors and platelets in disseminated intravascular coagulation can result in life-threatening hemorrhages. Also very important that DIC is secondary pathological condition, never primary. Causes is very large, can cover cover many disorders, can result due to infections, develop due to infections, all kinds of shocks, respiratory distress syndrome, acute intravascular hemolysis, massive tissue destruction, or tumors, or obstetric and gynecological pathology, allergic reaction. All these disorders can result in DIC syndrome. Here is pathophysiology of DIC, and you see here how disorder sepsis, for example, endothelial injury, massive tissue destruction, all of them can result in releasing of tissue factors and cause platelet segregation reaction, platelets increasing of platelets aggregation, which cause cause formation of clots, and widespread spread microvascular thrombus. Widespread microvascular thrombus can result in vascular occlusion and cause the ischemia and tissue damaging. In one hand, it will be platelet segregation and consumption of clotting factors and platelets. Consumption of clotting factors and platelets cause increasing of bleeding, increasing of coagulation factors, or increasing of anticoagulation factors and cause bleeding. On the other hand, it will be activation of plasmin and fibrinolysis, fibrin split products, and proteolysis of clotting factors, which result in also bleeding. And here we have stages of disseminated intravascular coagulation stages. First is hypercoagulation phase and platelet segregation, generalized microtubule formation, and centralization of blood circulation. This stage is compensated. Hypercoagulation stage, we formate generalized thrombus. On the second stage, we have consumption coagulopathy, when platelets and coagulation factors deficiency develop, this subcompensated stage. And third stage is deep hypercoagulation, massive fibrinolysis, profuse bleeding. This stage is decompensated stage. And fourth stage, reconstructive or sometimes maybe recovery process of if develop multiple organ failure, of course, result in death. Maybe DIC maybe three types: acute up to 2 or 3 hours, subacute from days to 1 to 2 weeks, and chronic months and years. And here is pathogenesis, how due to sepsis may develop the DIC syndrome. And you see sepsis can increase the pro-inflammatory cytokines, which enhance the monocytes and monocytes action, and which result in the destroying of endothelium and cause the plasminogen activators, inhibitors, insufficient removal of this and fibrin deposition. Over fibrin deposition may trap the whole blood cells, platelets, and RBCs, and cause the thrombus formation. And this thrombus will formated disseminated in different kinds of organs when formated systemic thrombus. Diagnosis of DIC, this clinical setting, laboratory test, and criteria is underlying disease known to be associated. Of course, this most severe disorders: initial platelets count less than 100, or rapid decline in platelet count, prolongation of clotting time, prothrombin time, and activated partial thromboplastin time, presence of fibrin degradation products, low levels of coagulation inhibitors, and low fibrinogen level in severe cases. Laboratory result: prolonged PT, APTT, and TT, and reduced fibrinogen level, increased DDMERS, and thrombocytopenia, and microangiopathic changes in blood film. Of course, I am ending my lecture, and for those who wants to know more, I am giving you normal platelets count. It should be 150 to 140 platelets per milliliter of blood. Less than 20, it may cause the spontaneous bleeding. Also, you should know bleeding time from 2 to 5 minutes, prothrombin time, activated partial thromboplastin time, and fibrin degradation products. Platelets count, here is again platelets count, Duke bleeding time, it should be within 2 to 4 minutes, Decay bleeding time will prolonged in thrombocytopenia and thrombocytopathias. And bleeding time IV methods should be within 2 to 9 minutes. It also will prolong during deficiency of platelets and also destruction of function of platelets. Activating partial thromboplastin time (APTT), which is initiate which indicate the intrinsic pathway and also general pathway, may prolong in coagulation disorders like hemophilia or in DIC syndrome. At normal range is 25 to 39 seconds. And whole blood clotting time, 5 milliliter of blood is placed in glass container, kept at body temperature and observed. Clot should occur in 5 to 15 minutes. Prolonged give us severe deficiency of any of the coagulation proteins. And also clot should retract in 30 to 60 minutes. Prothrombin time, we measure quality of the extrinsic pathway as well as the common pathway of coagulation will increase in coagulation disorders. Prothrombin time, which should be within 12 to 15 seconds. And also we should know international normalized ratio. It should be between the 1 and 1.4. This is a relation between the prothrombin time test and prothrombin time in normal. Thrombin time, we also discussed about thrombin time, also representative of coagulation disorders. And also clot retraction time, the time required for blood clot to separate from the tube wall and express serum, usually completed in 18 to 24 hours, but retarded or absent in person with thrombocytopenic purpura or thrombocytopathias. And fibrin degradation products, this mostly representative of DIC. D-dimer also to represent of the DIC, reference values is 33.5 to 727.5 nanogram per liter. And thank you for your attention. If you have questions, please you can put under my